started. And so this is sort of an anonymous test yourself sort of thing. If you want to put something in the chat room, what your impressions were or why you thought that or not, that's fine. This is kind of an important skill, if you will, because you're going to be faced with a series of unknown slides on the board examination where they're going to expect you to be able to look at a slide, in some cases make a definitive diagnosis pretty quickly, and then answer a second order question. There'll also be slides where you're given a whole, list of digital slides to look at, images, and then you need to just choose an answer. I don't believe, at least at this point, there's any just look and then write your answer in, but that something in the future might be available if things are going digitally. But at least it's important to kind of have unknowns, quiz yourself, see how you do. So we don't have the ability really to call on anybody here, but we can at least kind of have you go through and see what you think, and then we'll discuss some of the points about that. We have 15 cases, got about an hour, so we'll kind of go through these. So what I would normally do would be just to kind of ask for a volunteer who wants to describe this. And so what I would hope that you would say when you first look at it is that it was a shave biopsy, and then ask yourself whether you think it's an inflammatory or neoplastic process or possibly some kind of a hematomatous condition, something along those lines. Whether you think it's benign or malignant, what kind of differentiation it's exhibiting, and then what the differential diagnosis or the final diagnosis would be. And so here you see a shave biopsy of a little small round papular lesion that's in the dermis. There's no contiguity with the epidermis, and it looks pink. And at low power, you can see there's some little white clefts here. So there's some clefting going on. And then as we go to higher magnification, you can see all of these clefts, these thick sclerotic collagen bundles, some dilated blood vessels, basically no inflammation. So it doesn't look like an inflammatory process. It looks like either a neoplastic process or some kind of a hematomatous condition. We say, is it epithelial or non-epithelial? Non-epithelial, it looks like it's involving mostly the stromal collagen or maybe elastic fibers or something like that, but it certainly doesn't look like it's any epithelium that we would see. So benign based on the overall architecture, seems to be non-epithelial. It's got these thick sclerotic collagen bundles, and we all remember what the histologic criteria for sclerosis is, increased thickness and homogenization of collagen bundles with a decrease in the number of fibroblasts. So we have that here. And then we have these little clefts between them, which is very common in this entity. So I don't know if anybody wants to kind of write in the chat box what you think the diagnosis is. Presumably, hopefully people got the answer correct. Yeah, we got a few folks that are answering. Good. Sclerotic fibroma. So I put fibrotic scleroma. It's like the opposite of the approach, but yes, this is a sclerotic fibroma, very good. So now let's say that this is what the lesion might look like clinically. They're usually just skin-colored papules that are pretty firm. So what diagnosis, what entity do you have to worry about that's associated with sclerotic fibromas? Good, Cowden's disease. Excellent. You guys are on top of this. That's what we want. So this would be a pretty easy one on a scale of 1 to 10, probably maybe about a 1 or 2 in difficulty. So these are usually skin-colored lesions. Usually clinicians don't know what they are. They get sent into us like warts or things like that. They don't really think about them. If they're present in multiplicity, then obviously you think about Cowden syndrome. Now, who knows what Cowden syndrome is and what we have to worry about in Cowden syndrome? Yeah, you have to worry about underlying malignancies. So these are just a few other items that are in the differential diagnosis. Generally, none of these really fit too terribly well when you see this sort of plywood type of pattern. But yes, those of you that are writing these underlying malignancies, and yes, the P10 mutation, that's very important to remember that as well. The boards love to ask, anytime there's any genetic component of something that they've learned about, they like to ask it. So basically that's exactly right. So these are the kind of things you want to worry about. So it is part of this P10 hamartoma tumor syndrome, which is this loss of function mutation in the P10 gene that results in this hyperactivity of this mTOR mammalian target of rapamycin pathway. So basically what this mTOR does, it's involved in intracellular energy, and when it's upregulated, it results in cellular hyperactivity with proliferation. And these are some of the cancers that you get. Now, other things that are associated with Cowden's, in addition to the sclerotic fibromas, are keratoacanthomas and trichotillomanias. And we all know that you can also get sebaceous keratoacanthomas in patients with the Muratori syndrome. So KAs and K-like lesions can be seen in a lot of different settings. You get KAs here, KAs in Muratori, multiple keratoacanthoma syndromes, KAs associated with BRAF inhibitor therapy. We talked about that previously. So just remember that you can get multiple KAs in a lot of different settings. So that's an important thing to remember. Also, just remember Cowden syndrome is one of the ones where you can see it in. And these P10 hamartoma syndromes may be amenable to treatment with topical sirolimus, just like angiofibromas with tuberous sclerosis can sometimes be treated with that too. So just remember that. So these are some of the other P10 hamartoma syndromes. I would recommend learning about these others. This Bannian-Riley-Ruvalcaba syndrome, which I believe has got some vascular abnormalities with it as well. And then there's the Proteus syndrome too. That's associated with this P10 mutation. So this is important. Boards love to ask these kind of questions about this. So make sure you have good knowledge of some of those other relatively rare P10 hamartoma syndromes. Okay, here, incision biopsy, maybe a deep punch biopsy, low magnifications, kind of subtle, doesn't really show much. So the real action here, when you look at the slide, was down in the fat and the lower reticular dermis. And we had all this purplish material that's present diffusely in the fat here. But also, if you look at some of these other areas involving blood vessels here. Okay, so small blood vessels with soft tissue calcification. So anytime you see this purple crystalline material, that's almost always calcium. Okay, so we got calcium, we got a deposit in blood vessels. And then if you look here in this blood vessel, there's also this pink homogeneous hyaline-like material. So you guys know what the diagnosis is here. I'll pull up the chat again. Let's see if we got any answers. I'm sure we have some right answers in here. Good. Calciphylaxis. Excellent. Calciphylaxis. So this is what the skin lesions might look like. Again, they look like this because the skin is necrotic overlying it. This is basically an infarct due to dystrophic calcification in these little blood vessels with thrombosis. So you kind of need the calcium alone probably isn't enough to do it. You really need to have compromise of the blood vessel lumen as well to give you the secondary overlying ischemic infarctions. And these are often associated with protein S, protein C deficiencies. Now you all know where this is seen most commonly, obviously, renal failure, that sort of thing. So when you get somebody that has this, you want to make sure that the calcium phosphorus product is not abnormal, make sure they don't have a lot of hyperparathyroid going on. But now that we've seen this for the last 15, 20 some odd years, we do see patients that don't have renal disease that have this on occasion. So it's not confined to patients with renal failure. And used to be, when somebody would get this in the old days when I was a resident and whatnot, it was like a death sentence. But we've actually had patients today that have actually done better. If you get their parathyroids out, if they have markedly elevated parathyroid hormone levels, that helps. You can put them on sodium thiosulfate, can help. So there are ways that you can actually treat these patients and keep them alive, but one of the problems is because the skin breakdown, they end up getting open ulcers and then get secondary sepsis and things like that. So not a good disease to have. Basically, this is kind of like almost a dermatology emergency. If you diagnose this, you want to notify the team right away. Usually they know the patient's got renal disease, but you still want to, make sure, I've had cases where we were the first ones to kind of notice that everything was going wrong. So you want to make sure that you let them know if they've got calciphylaxis. Now this comes from my good friend, Warren Piet. He actually gave a real nice talk at our conference the last couple of years on different patterns of purpura. Now this is different than leukocytoclastic vasculitis, but if you see, palpable purpura, you see sort of non-inflammatory purpura. If you look for different patterns of it, and he calls these four patterns that we see most commonly, the multiple lesions that are dependent, the small number of lesions that are random, and then acral lesions, and then widespread multiple generalized lesions. If you see different patterns like this, different diseases tend to cluster in these different patterns. And so calciphylaxis is really probably more, in this case at least, it was more kind of this relatively few number of lesions kind of randomly distributed in this case. And that's kind of the way calciphylaxis tends to kind of go. So this is a good chart. It kind of shows you the different patterns clinically of these various purpuras that develop. And depending on what you see clinically, you can kind of predict on what the patient's got underlying it. So, if they have a lot of occlusion like this disease, it tends to be fewer numbers of lesions, random. So again, the PANs, the ANCA associated conditions tend to give you that pattern. The cold-related lesions tend to be acral. The lower legs we think of as the leukocytoclastic vasculitis. And if it's widespread, then you think of it maybe as a drug or some kind of a viral illness that's causing it. These new COVID-related, widespread diseases that are vasculitic, in some cases, tend to give you that pattern. So again, looking at the clinical, you can kind of figure out what's kind of going on histologically. Okay, here we have another deep saucerization, maybe an incision biopsy here. Shows a well-circumscribed area right here. If you draw a line right down the middle of it, it looks very symmetrical, so it looks like a benign process. There's a lot of blood vessels here. So probably a neoplasm, or if it's not a neoplasm, it's a reactive process with a lot of blood vessels associated with it that makes it look kind of like a neoplasm. So, like a pyogenic granuloma, for example, not really a neoplastic process, it's more of a vascular proliferative process, but it's analogous to a neoplasm in some way. So let's go to higher magnification. You can see these are markedly thick-walled blood vessels with this very, very large endothelial cells that are protruding into the lumen. And many of these endothelial cells have these vacuoles in their cytoplasm. Now, again, I don't know if anybody knows what that's called in the histology microscopically. If you want to put that in the chat room for an extra bonus question, you can do that. But notice the markedly thick-walled blood vessels, and then also notice that there's some inflammation in the periphery. And anybody know what these cells are? Hopefully you can recognize those. Here's another area where there's a dense nodular lymphocytic infiltrate with these red cells with the red cytoplasm and the bilobe nucleus, so they're eosinophils. So hopefully you guys know what the diagnosis is here. Pull up the chat room again here. Okay, good. Angiolymphoid hyperplasia with eosinophilia. So these are pretty easy ones for you today. So this is, we're not giving you anything that's really tricky so far. Hopefully these are just right down the middle of the fairway. I like to play golf, so these would be easy, obvious lesions that the board would expect, probably in the 90% plus range to get. These aren't tricky, pretty straightforward. And I don't know if anybody knows what those intracytoplasmic vacuoles are, but Weibel Palade bodies, the board's not going to ask that, but that's just what those are called. And that's pretty characteristic. So when you look at angiolymphoid hyperplasia with eosinophilia, you don't always have to get the eosinophilia seen in the biopsy. We usually do, but you don't have to. They're usually associated, though, with the big, thick-walled blood vessels and the prominent endothelial cells. So those are present every time. You need that all the time. And then if you get the lymphoid infiltrate with the EOs, that's helpful. Sometimes they have circulating eosinophils. They don't actually have to be in the skin lesion, but they usually are in the vast majority of cases. Kind of controversial as to what this disease actually is. Some people think it's a reactive inflammatory process with blood vessels. Other people think it's kind of a vascular malformation with a pseudolymphomatous reaction. This depends on which side of the border you like to be on there. But the main thing is for you, just make sure you know how to diagnose it. Now, I'm sure, especially you third years on the session today, know what the classic histologic differential diagnosis of this is, and it's not this. Clinically, it looks different than this. So anybody know what that other disease is? It's kind of a histologic identical twin that we always have to kind of distinguish from this. Write it into the chat room if you know it. You don't know it, that's okay. Kimura's disease. Okay, that's kind of a widespread form of angiolymphoid. Yes, a couple of people wrote that in. Good. Kimura, which is a widespread form of this process, often seen in Asian individuals. So there's not just a few lesions on the head and neck area; they can get them all over the body. It was described in Japanese men, I believe, initially. Now, there's another disease that you have to make sure that you don't confuse with this, called Kitamura's disease. That's more of an epidermal hyperpigmented process, as I recall. So it's a different deal than this, but Kimura's is the one that you want to make sure that you don't confuse with it clinically. Okay, let's look at the next one. All right, now we've got what looks like an inflammatory process. So as we work through this, what's the pattern? It's a superficial perivascular dermatitis with also some interstitial inflammation here. And this one was a little bit harder. So this one's a little harder because it had some little bit unusual features under the microscope. So again, if we just show you things that are obvious and classic, I mean, that's great, but you know, the board does like to put a few things on there to make you think about it. So superficial perivascular and interstitial infiltrate, and notice at low power that the interstitial infiltrate is comprised of cells that are different than the cells around the blood vessels. So even at low power, these are dark and blue and black, so they're probably lymphocytes. These cells that are interstitially here are paler, so they're probably histiocytes. So at low power, when you see lymphocytes around the blood vessels and histiocytes interstitially, and as we go to even higher magnification, there's some mucin here. So I don't know if you guys have any ideas what the diagnosis might be, but there's also some other confounding variable here. There are also these cells, just like we saw in the last case, that are eosinophils. So we've got a perivascular infiltrative lymphocytes, interstitial histiocytes, mucin with eosinophils, and if you kind of go back here, there's even a little area where there's maybe a little small blister up here for some reason or other. So I don't know if you can kind of put this together. Sometimes you have to kind of do some mental tricks. So maybe if you subtracted out the eosinophils and said, well, I've got a perivascular infiltrated lymphocytes with these interstitial histiocytes and mucin, yeah, looks like GA, granuloma annulare. But what are the eosinophils doing there? Why are they there? Do we normally see eosinophils in GA? No, not really. So yeah, it's possible it could be drug-induced, but just so you'll know, and this is a relatively rare phenomenon, sometimes GA gets induced by other things. So some people are saying drug-induced GA, that's a possibility. Sometimes patients give a pretty good history of getting an insect bite, and then they get this GA that develops at the site of the insect bite. So that's probably, in this case, what happened. This was the patient developed a relatively few number of lesions. It wasn't a widespread process like the so-called drug-induced GA can be. And most of the drug-induced GA, I mean, I'm not really sure it's drug-induced GA. It's probably more of a granulomatous GA-like drug eruption that we see. And most of those actually don't have eosinophils in it, but that's not a bad idea to think about that. But just realize that rarely, sometimes in GA, you can sometimes get eosinophils. So just remember that. I don't think they would show you this one on the board examination because it's a little bit tricky, but just so you'll know, it's a little bit of an unusual pattern and it probably didn't look like this clinically. But this was an example of GA, and the pattern was largely interstitial as opposed to being palisaded. Most of the interstitial GA that we see does not have eosinophils in it, and it usually doesn't have as many lymphocytes as this one had, but this did have a largely interstitial as opposed to a nice palisaded pattern with mucin in the center of the palisade. So anyway, that's just something to remember. And there are a lot of different other forms of GA than the interstitial type, or maybe the type that gets induced by a drug, or the type that maybe gets induced by an insect bite. Anybody know what some other clinical and histologic manifestations of GA are? So we've got the classic ring palisaded form. We've got these forms we talked about. You can get a diffuse form. Deep GA, also known as pseudo-rheumatoid nodule, subcutaneous GA, perforating GA, good. Those are like little skin-colored papules with some crust on the surface of them. So yeah, so there are a lot of GA. Sometimes we look at GA in an early stage, it can have some central vasculitis associated with GA. And then of course we see the GA-like conditions, the interstitial granulomatous dermatitis associated with rheumatoid nodules. Yeah, so you can lump that in a little bit. Annulare elastolytic giant cell granuloma that somebody wrote over there, that's exactly right. I view that as being a manifestation of a form of GA that may be sun-induced or related to sun exposure. So those are all things that kind of fit into the overall spectrum of palisaded granulomas that a lot of people include in the form of GA. So that's good. Excellent. Always a good idea to stretch your brain a little bit. Okay. Here we've got a little bit higher magnification view of a lesion. The low power of this view was a round circumscribed lesion in the dermis that had largely kind of been enucleated. Okay. So again, inflammatory or a neoplastic process. And now we've got all of these little spaces here with these small cells here with this pink hyaline-like material within it. Okay. So I don't know if anybody's got any ideas here about this. Good, somebody's written the right answer down already. IPEH, or intravascular papillary endothelial hyperplasia. Now, it kind of looks like this. And anybody know what causes this? What's the pathophysiology of this entity that's got this long name associated with it? Yeah. Not so much ischemia from a clot, but yeah, this person Drew wrote down correctly. Excuse me. It's basically a blood vessel or even a hemangioma that gets traumatized at thrombosis and then it undergoes organization. So that's the key to the diagnosis. And the most important thing here is to remember that this is not an angiosarcoma. It's basically just a normal reactive vascular process. Whenever you get a blood clot inside a blood vessel for one reason or another, when it undergoes organization, it looks like this. So if you, it can sometimes simulate a neoplasm, but basically you look at the low power here also to help you make the diagnosis. This is a well-circumscribed lesion, and basically it's just a clot that's undergoing reorganization. The person's name that's associated with it is Masson. So basically, just think of it as a clotted blood vessel or a clotted hemangioma that's traumatized and then undergoes this organization. Now, there are a couple of other settings where you can get blood vessels that kind of get thrombosed for one reason or another, and then you get a vascular proliferative condition associated with that. Does anybody know a couple of other scenarios where you can get blood vessel proliferation where you see ischemia or clotting of blood vessels for one reason or another, and it occurs secondary to that? Sort of not exactly like this, but somewhat in the same general sort of pathophysiology of this. Okay, don't everybody chat at once there. But there are a couple to remember. So patients that have POEMS syndrome, POEMS, the polyendocrinopathy and macroglobulinemia, those kind of things. What happens in those situations is they get tiny little blood clots in the blood vessels over a small, they're slowly developing. They get microscopic areas of ischemia. They get a secondary vascular proliferation, and they get these little tufted hemangioma-like lesions that develop because of the ischemia secondarily to it. And you see the patients, they have multiple little vascular lesions all over their body because of this. So just remember that that's another situation where you get secondary vascular proliferation, where you get the individual's tiny ischemic sort of changes in the blood vessel due to precipitation of this protein, macroglobulinemia, that develops in those patients. It happens more in that condition for some reason than it does in patients that have circulating, ingus and that sort of thing, where they get more of a vasculitis. And the other setting where we see this is a patient with stasis alterations, stasis changes. Low-grade ischemia, they get lividovasculitis-like changes associated with stasis dermatitis, and with stasis ulcers. They get prominent vascular proliferation, but they get fibrin clots inside the blood vessels, and they get the secondary vascular proliferation that occurs secondary to that as well. So those aren't really the same thing as thrombi, if you will. But basically it's where you get the precipitation of either fibrin or a circulating protein and gets that. So the question here, yes, is this on a spectrum of dermoangiomatosis? In a way it is, sort of like that. Not exactly, because that's more kind of where you get ischemia, you get secondary vascular proliferation. But yeah, all of these things are sort of in the same general category. You get abnormal changes occurring with the blood vessels, and the blood vessels react. Sometimes they react quickly like this, so they clot and recanalize and try to get back to normal as soon as possible. Sometimes they're sort of like reacting slowly, where they're getting these tiny little blood vessels that form almost kind of like probably people that have ischemic heart disease and get secondary vascular regeneration or collateral circulation. Probably similar sort of thing is going on in your skin when you get these kind of situations in those situations. So yeah, they are kind of in a spectrum, if you will. Okay, this one's a good one. This is one of your follicular tumors, okay? So the shaved biopsy, epithelial neoplasm, small, symmetrical. And notice how this is oriented in a horizontal plate-like fashion. You get these little articulated epithelial proliferation with these clear staining areas here. And whenever you see this kind of plate-like horizontal distribution like this, think that it's sort of analogous to the mantle zone is where this thing is maybe developing from. That maybe it's kind of coming from this area and kind of spreading horizontally or laterally. I don't know if that's happening, but that's kind of a way to really think about it. And notice that it's got this clear staining cytoplasm here. So who knows when we see that clear cytoplasm in the epithelium that looks like it's recapitulating a primitive hair follicle, what part of the hair follicle do we think that's recapitulating in this situation? And anybody know? Well, this is tumor follicular infundibulum, that's right. But yes, this is really more the outer root sheath of the follicle. So the right answer for what's the diagnosis of the neoplasm is yes, this is tumor follicular infundibulum. But the right answer of this type of differentiation, this glycogen containing cells here, is outer root sheath of the follicle. Okay, and that's also seen in trichotillomania, trichotillomania verruca. Yeah, so outer root sheath, or put that up there, is correct. So again, if you have the mantle zone, it can recapitulate the entire little mini hair follicle. Give you outer root sheath, give you infundibulum. So whenever you see this little thing here, where you get stratified squamous epithelium inside a little small cyst, that's infundibulum differentiation. And when it gets kind of pink, homogenized, hyaline-like material, that's more like the isthmus. You see that when you see like an isthmus catagen cyst, that's tricholimal differentiation of the inner root sheath of the follicle. So that's what we see there. So yes, this is a tumor of the follicular infundibulum. So again, you need to make sure that you know your follicular tumors. We talked about that a couple of weeks ago. So these usually they don't look so much like that, but they usually are kind of solitary little skin colored papules. Clinicians don't know what these are. They never make the diagnosis. They send them in usually as a rule out basal cell or a wart or something like that. They're totally benign. They don't really need any therapy. But just remember, this is one of the follicular tumors that's oriented kind of horizontally as opposed to vertically. Now, there's a couple of others that can be mostly horizontally oriented. Seborrheic keratosis, maybe like a clonal SK might be the differential diagnosis. But what's another one that is a neoplasm with follicular differentiation that's also got a prominent stroma associated with it? When you look at a low magnification, it looks like most of the action's going on kind of in a horizontal fashion as opposed to like a nodular fashion. And then you look at a higher magnification and it's more primitive, inferior portion of the follicle with basaloid cells that are palisading and clefts between them and the surrounding stroma. Who knows what that is? Good, fibroepithelial tumor of Pincus. And those look different. They usually look like a skin-colored papule. They're often on the trunk or the extremity. And one of the things about a fibroepithelial tumor of Pincus is because it's got that fibrotic stroma, you can't really treat those with desiccation and curettage. They're probably low-grade basal cells. They tend to behave less aggressively than a basal cell. But because of that stroma, they're not mushy like a typical basal. So if you're going to treat those, you really need to excise them because it does have a different type of stroma than a classic basal cell. Okay, this one also hopefully was fairly simple for you. A shave biopsy. And is it an inflammatory or a neoplastic process or maybe a deposit, something different? So we're not sure. It's theoretically possible it could be a neoplastic process that's got a lot of this material in it. So if it is a neoplasm, it's certainly very benign, right? It almost looks like it's got a ball and claw-like morphology, super well circumscribed, very small, so totally benign. And as you go to higher magnification, and this is very, very important to make sure you recognize what we're looking at here. This is very important, fundamental for histopathology to know what this material is right here that we're showing you. So if I were writing a board question, I might possibly flash this up here and say, this material is what you're saying, mucin, and what is the actual chemical composition of this material? Yeah, hyaluronic acid. And what are these cells at this power? I'm not even going to go to higher magnification. I'm just going to make you decide right now by looking at it there. What is that cell? A mast cell. Good. Whenever you see mucin, mast cells live, they go with that. And then these are fibroblasts over here. So yeah, this is hyaluronic acid. So yes, this is focal cutaneous mucinosis. And in this situation, it probably looked like a little tiny papule. Now, there are other scenarios where you can get mucin deposit in the skin. So you can get like a deep diffuse mucin. We talked about this last week, remember? We talked about some of those weird cases where there was that kid that had that Hurler's disease, which is a disease where they get widespread mucin all over the whole body, mucopolysaccharidosis. So you can get that. You can also get like a deep, you get myxoid changes in things like myxoid lipomas. You can get mucin in other kind of cancers. So, and then you can also get myxoid lesions associated with systemic illnesses, with like syndromes. So who knows where you get myxomas associated with cardiac disease and lentiginoses and things like that. What's the diagnosis there? Carnies, good. So here, it looks like this, a little small papule. So yeah, this is just a little focal cutaneous mucinosis. So just make sure you know all the settings where you can see mucin. So you can see mucin in association with inflammatory diseases like granuloma annulare, lupus. You can see it associated as a deposit, like pretubercular myxedema, some of those polysaccharidoses we talked about. You can see it here, just a coincidental process. You can see in a lot of things. Now there's two different types of mucin in the skin, right? There's hyaluronic acid, which is connective tissue mucin, associated with mast cells and fibroblasts. And then there's one other type of mucin that's epithelial mucin. What's that mucin called? Sialomucin. Good, excellent. Sialomucin. That's an epithelial mucin. Okay, so the mucin that comes out of the goblet cells and in your GI tract, that mucin, that's sialomucin. So in follicular mucinosis, for example, that's epithelial mucin. It's not hyaluronic acid in that situation. So there's two different kinds of mucins. Just make sure you know basically generally what they are and where they're located. So that's basically focal cutaneous mucinosis. Yeah, this entity that's listed here, superficial acral angiomyxoma, that's got a lot more blood vessels to it, and it's often seen in the nail area. Okay, so this one was, this month's in 2016 was a real easy one. These are all softballs, so hopefully you guys got most all of these correct without any problems. So you've got a shave biopsy, acral skin, papular lesion, got all these structures in here that are kind of irregular in size and shape. Anybody know what these structures are here? Nerves, good. So what's the diagnosis? Well, it is a traumatic neuroma in a way, but yes, it's actually an accessory digit. And they come in, they look like these little papules like this. They're often seen around the fingers in this area. I think there's a picture of that in a minute. And so what happens is these things get traumatized. They get often amputated in utero, and there's often a little nubbin that's left there, and somebody biopsied and it looks like this. And it is really a form of a traumatic neuroma. So that's really what we're looking at is a traumatic neuroma, but that's kind of what's left over from the accessory digit like that was present here. And sometimes you'll see an accessory digit that shows really looks like a little teensy tiny finger. It's got a little small focus of bone, it's got a little focus of cartilage. So if you get one that hasn't ever been damaged, and it's a really and truly one of those, you'll see that component of it. But if it's been maybe auto-amputated and this little tiny papule that's left like this, and you biopsy it, this is usually what it shows. So yeah, it does look like a traumatic neuroma. So that's a supernumerary digit that doesn't have all this cartilage, nail, and everything in it. So just remember that that's what these things usually look like. And obviously the difference for diagnosis here would be acquired digital fibrous keratoma. That can look a lot like this, maybe rarely, you know, an acral angiofibroma that you might see with tuberous sclerosis, but that doesn't give you all the nerves that we would see here. So again, that's a pretty easy one. And it is a type of traumatic neuroma, actually. So we'll talk more about some other neuromas in the future. Okay, got a punch biopsy in this case, and it's got some large sebaceous lobules. And then if you look down here, there's maybe a couple little fibrous streamers. And so at low power, it kind of looks like it's from the face, okay? But it's not the face. I'm just gonna tell you, this actually came from somebody's scalp. So if it looks like the face and it's on the scalp, and you got all these large sebaceous lobules, say, wow, it's got to be an alopecia because there's not any deeply seated hair follicles. There's only one left here. There's a little fibrous streamer over here. So if you just looked at this at low power, you might think this is the face. But so you say, well, this guy's, if it's on the face, it looks like, if it looks like the face, there's no hair follicles, it's probably got some background androgenetic alopecia. So that's, we talked about that when we talked about the alopecias views. So there's definitely some androgenetic alopecia going on here. However, if you start looking at the individual follicles, there's a fracture of the internal root sheath here. And then there's also this hair shaft that's disrupted and fractured here. So there is some pattern alopecia, you're right, but yes, good, I'm glad you picked up on that, that there's also a manifestation of trichotillomania in this slide. So this is a two for the price of one. Get your money's worth here. So there's a trichomalacia, fracture, damage of these hair shafts, and also the sort of shearing of that internal root sheath. So this guy was probably, may have been a teenager or something, had some background androgenetic alopecia, maybe whatever, but also was nervous about maybe taking finals and started twisting and pulling on his hair. So we got basically trichotillomania. So we talked about this, we talked about alopecia a few weeks ago. Hopefully, and those of you that recognize that, that's good. And hopefully you recognize it without me having to aim at the arrow at the follicle. So on the board examination, you're not going to have a professor or me or somebody sitting at your elbow saying, make sure you look there. So you need to train your eye where to look. So make sure you do that. And I think they would probably, on something like that, probably give you something even more impressive than just one or two broken off hair shafts. We're trying to get these unknown slides and cut multiple sections. You know, sometimes we don't get, it's hard to get areas that show multiple areas with trichomalacia. So that's a good thing about digitized slides. They can show you a perfect example that everybody gets to see. So they'll find a good one that's got lots of trichomalacia in there, and that's pretty classic. So but just make sure you understand the diagnostic features of trichotillomania, the trichomalacia, the fractures, the damage to the actual hair shafts, and variable amounts of inflammation. Sometimes there can be a lot, sometimes there can be almost none. Okay, biopsy technique here was done by enucleation. So again, we think of shave, we think of punch, we think of excision. Well, here they maybe did a little incision. They thought they were going to pop out the cyst, and something did pop out, but it wasn't a classic cyst that we see, right? So it shows a benign looking lesion, but it's got an epithelial differentiation. Okay, we're going to higher magnification, and it's got these papillary-like frond-like structures here, and it's got the some inflammation in the center of these, the stroma, with these dilated little duct-like areas here. And so anytime we look at an epithelial line structure, we want to see what that lining is. So as we go to higher magnification, what kind of differentiation are we looking at here? Classic. Good, apocrine, the little snouting up here, the decapitation secretion. And then we've got an infiltrate in that stroma. Often you'll see plasma cells like here. This one actually has to happen to have some eosinophils also. And this is what the lesion looked like clinically. So somebody said S-CAP, H-PAP. Yeah, I like H-PAP a little better. Now, what's the difference? Now, it looks like syringocystadenoma papilliferum when you just look at the lining, right? But if it looks like a cyst, it's more likely to be Hidradenoma papilliferum, right? Because syringocystadenoma papilliferum is a warty, plaque-like lesion. Hydradenoma papilliferum is a cyst-like lesion. It's often seen in the groin area. Doesn't have the verrucous change to it that you see with syringocystadenoma papilliferum. And it often, those are associated with nevus sebaceous, and these obviously are not. So this is a Hidradenoma papilliferum. This is what these lesions might look like. They're often eroded, they're kind of oozing, and sometimes they just have a slight connection to the epidermis. The genital area is a really common location. So again, this is a Hidradenoma papilliferum, often seen in women far more commonly than men, and basically it looks just like this. It's a cyst with this papilliferous morphology to it, papillated morphology, often plasma cells in the stroma with the classic lining of the apocrine differentiation that we see here. Okay, shave biopsy. This one was a little harder. You had to kind of look, and somebody said, do they always have plasma cells? Well, nothing in dermatopathology is always, except maybe molluscum contagiosum, but no, they don't have to, but the vast majority of them do. So here we've got a shave biopsy. It's pretty subtle. We don't see a lot when we're looking at this at low magnification, and there's really not much inflammation. But this power, we do see something. There's something kind of dark here. And you go to higher magnification, you've got this little dark brownish black material here. You've got this kind of granular materials on these little structures here. And maybe some of them are also present over here near this, it's probably a little sweat gland over there. And we've got these little granular particulate structures, and notice where they're located. Yes, they are staining the actual elastic fibers. So yes, somebody has put the right answer in here. This is argyria, cutaneous argyria. Okay, now notice what's happening in argyria. It's actually staining, precipitating on the elastic fibers. And that's helpful because basically what's happening here, this isn't really an inflammatory disease. This is almost like a in vivo special stain. And there's two ways to get argyria. There's one way, if you drink silver-containing products or you use silver-containing eye drops or nose drops or something like that, that's a systemic argyria. Or you can get it like this, a little papule. How do you think this guy got it? By trauma. And probably, yeah, nose ring. That's one of the most common things we're seeing these days, these nose rings, these umbilical, belly button rings. Sometimes the classic thing we used to see in the old days wasn't the ring, It was the amalgam tattoo in the dental area, because when they use silver amalgam, not mercury amalgam anymore, they use silver amalgam. And so when they're putting in your fillings, well, I used to get my teeth filled when I was a kid. They would use that stuff and squeeze it into there after they drill your teeth. Now they use porcelain and all other sorts of stuff. But back in the old days, they used silver amalgam. And I would give you this amalgam tattoo that would get biopsied every now and then and send as rule out melanoma. And it shows this exact finding that you see here with silver granules that deposit on the actual elastic fiber. So just think of this as basically being a silver tattoo. And there are other things in the differential diagnosis. We don't have enough time to get into all these today, but you should know your various metals and how they can affect your skin. Okay. This is a very good biopsy here. We've got a punch biopsy, and we see lots of thrombosed blood vessels here with ischemic necrosis. Lots and lots and lots of those. So you can imagine what this looked like clinically. Everything is dead here. And it's dead because you've got all of these blood vessels that are primarily thrombosed with relatively limited inflammation. There's some inflammation here, but notice that we don't have a lot of leukocytic aplasia. We got mostly thrombosis with some neutrophils, most of which are intact. Now, remember we talked about vasculitis a few weeks ago, and we talked about leukocytoclastic vasculitis, which is mostly inflammation, and then the thrombosis in the blood vessels come along secondarily. Here we've got lots and lots of thrombosis with some neutrophils. Okay, so coma blister, that's one thought. That's not a bad idea. So that's one thing you would think about, not a bad thought. But there's a few other things that you have to think about here. Also vasculopathy. Good, maybe do cryo. Now this on a scale of 1 to 10 is like 11. This is massive thrombus. And if you see cryo, it's usually a few small blood vessels superficially. It's kind of hard to see that at low magnification. When you get this extensive involvement with some infiltrate, with some polys, that's a little more inflammatory than most like cryos and things like that. Sepsis is not a bad idea, but usually more inflammation than that. DIC possibly, but you have to think about one other thing today, especially when you get this much inflammation with these areas of vascular thrombosis that's killing everything. It would look like this, like Warren's picture that we talked about. So we've got to think in a negative way today. In our climate, what if I showed you this picture on his ears? What do you think about? Levamisole, good. Levamisole, and it gives you a thrombotic vasculopathy, and it can give you a fairly dense inflammatory infiltrate with neutrophils, and it's associated with ANCA in many of these cases, okay? So for those of you that said thrombotic vasculopathy and things like that, you're right. That's exactly what this is. This is a type of vasculopathy. It tends to be more florid when it's associated with levamisole. So if you just got into that category, that's good. You're right. If the board were to show you a picture of it on the ear, then hopefully you would instantly reflex to the levamisole. And it is something that we should know about because it is something that dermatologists are going to be seeing on the front line. Now, the biopsies like we showed last week with the COVID, they give you the vasculopathy, can look similar, not usually as florid as this, but you also can get the vasculopathy associated with that. Not as many polys in that situation. So again, just remember that. And I think some of those patients actually have had some ANCA positivity in those cases. So again, it's analogous in some ways. So levamisole, it's adulterated in cocaine, and it gives you the ear involvement, the acral areas with the vasculopathy. Okay, this is another one. You had to have sharp eyes. So biopsy looks like a nothing and low power. So we go to our nothing differential diagnosis. So you have that hopefully. Start thinking about, well, gosh, it's in what part of the body are we on? That's helpful. Near volar skin. And then somebody said Tinea nigra. That's very good because that happens to be the right answer. So whenever you see a nothing biopsy, you work through things. So what other things might you think about? What if we didn't look in the cornified layer? We saw the superficial perivascular infiltrate around these blood vessels here with maybe a little bit of pigmentation at the basal cell layer. Yeah, TMEP. I hope you would think about that. That happens not to be the right answer, but still sometimes it's better to put something in the differential that it could be because you want to think about it because you want to miss it. So good. In this case, you look at the cornified layer, and guess what? You see the obvious pigmented hyphae. What do you think they submitted this to the dermatopathologist? What was the differential diagnosis? Good, melanoma. They commonly send this in as acrolentiginous melanoma because they think that's what it is. So this is what these lesions look like. The good news is it's not melanoma. These things usually aren't black, usually brown. And acrolentiginous melanoma usually will have at least some black in there because there's melanin that gets into the cornified layer. So if you see just something tan on volar skin, it's less likely to be melanoma in situ than it is something like this or maybe some other kind of thing that's going on here. Make sure you know some of the dermatiaceous fungus. The board doesn't ask a lot about fungus, but if you don't want to just toss a few questions and you want to get them right, spend a little bit of time learning about this. To me, it's kind of interesting. So it used to be Cladosporium wernickeii, and now it's called Horti wernickeii. But know some of the other things that can cause dermatiaceous fungal infections, Allochuria boardii, and some of these. Okay, we don't have time we may not have time to go through all the cases in extreme detail. So at low power here, we've already had paniculitis. This is a test, this is a review. We're not gonna go spend much time at high power here. What's the diagnosis? Good. Why erythema nodosum? Because it's a classic septal, mostly paniculitis, marked thickening of the septa, granulomatous inflammation at the sides of the septa, a little bit of lobular involvement, but we see that all the time too, mostly septal, thick septa, periseptal inflammation with granulomatous inflammation, erythema nodosum. Low power diagnosis. Low power diagnosis, high power mind, just like this right here. This is classic nodosum. So we can go to higher magnification. We can go look and see, oh yeah, there's be some multinucleated histiocytes, there may be some EOs, there may be some neutrophils, and yeah, it's all here as we would expect to see. But this is a classic, beautiful example. This is what the board's going to show you. They're not going to show you one that's largely resolved. They're not going to show you a weird case. They're going to show you something just exactly like this. They might even expect you to get it pretty quick, and they might ask you to name, some diseases that are associated with it, like high histo or coxy or, things like that. So, and you can get eosinophils in enodosum, as you see here. So nice example, pretty classic. Make sure you know this. Make sure you know all the things that be associated with it. So this is just, we need to know this. This is classic dermatology 101. So just make sure you know this, know the clinical, know the histology, know the associations. Okay, punch biopsy. Inflammatory neoplastic. Well, it's got a lot of epithelial cells here, things that are epithelioid. It's mostly in the dermis. It's very diffuse. They did a punch in the middle of this thing. That didn't look good. So whenever we see something like that, we get very concerned about the possibility of malignancy. It goes all the way to the base. Very atypical cells here. Epithelial differentiation, a lot of mitotic figures. So malignant epithelial neoplasm, and we'll go back to low magnification, notice that it's involving mostly the dermis, it's not involving the epidermis. So when you think about that, and you've got these aggregations of these cells, they're almost forming these cords and strands in some areas here, metastatic, good. And they're probably not gonna ask you to get into what kind of metastasis. They just want you to know that it is a metastasis. And they might show, if it shows clear cells in vascular areas, they might expect renal. In this case, it just happened to be breast. We don't need to know that so much. We just need to know that it's a metastatic malignancy, it's epithelial. They might ask some questions about what are the most common types of metastases that we see in the skin. Breast happens to be a very common one. We also see melanoma, we see squamous cell, we see head and neck cancers, salivary cancers, things like that, colon cancers. And some of those do look a little bit different. We're talking about the dirty necrosis in the large sort of glandular areas in the colonic cancer. They could possibly show you that and expect you to know that. But something like this, basically just say metastatic cancer, metastatic adenocarcinoma. This happened to be breast cancer in this situation. Okay, good. I hope you guys enjoyed that. It looks like you guys I appreciate you guys participating on the chat room. That's a nice way to do this. I think we'll do another one of these next week. We'll come up with another one to put on the website for you, so you guys can go on, look at these, test yourself, and then we'll go over like this again next week. We'll have the one posting for you probably as early as Monday, and we'll give you another talk on Monday. We'll post that as well. So thanks to everybody for being on, and have a good weekend, and we'll see you next week.